I'm going to talk to you about the new state antiretroviral guidelines. I was heavily involved in them in one way or the other. I'm going to show you the parts which I'm going to take ownership of and the bits where I'm going to completely deny any sort of responsibility for. And there are things in them which are problematic. By and large, they're very good. There are things which I'm sure many of you will pick up which are an issue. And I just want to take you through the process and maybe some of the politics and what it means practically for people within the state sector who are going to be giving these drugs, as well as for the private sector who may need to refer through. Just one final thing is that I'm part of the RHRU, and this is our logo here. We've just been given institute designation within the department, within WITS, and we'll be changing our name very soon. So it's not because I've jumped jobs, it's simply because we've become so rich and famous that we've actually had to go to the next size in terms of the university designations. So just to remind you, I'm a clinician. So some of the things I say and do and talk about will be really from a clinician's perspective. Most of my work's in and around Hillbrow and in Northwest, in rural projects there. But I'll be showing you some data from our project within Hillbrow to show you what you can do with antiretroviral therapy and what you can do in terms of access to these programs. So going back to the politics, I think many of us were very amazed when Barack Obama was elected, and he talked here very firmly about how we will restore science to its rightful place and wield technology's wonders to raise the healthcare quality. And I think they came from a stage where George Bush had a very anti-science agenda, and this is what you're getting. This is the difference. Remember when Mbeki said he didn't know anyone who's died of AIDS? Instead, Motsoaledi is coming out and say the country's burning. And I actually get exhausted listening to him on the radio because he's so passionate and so energetic and there's so many projects on the go. And this is what he said on March 29th. That each and every institution, when he was launching this HIV testing campaign, the principal will be tested. Every CEO of a hospital must start a nerve center and he must be tested first. How different is that in terms of leadership compared to what we've dealt with in the last 10, 15 years? Grave, Blade and Samandi, we will be training young people for the grave instead of for the workplace. I mean, when he talked about HIV prevention. This is a different country we're living in at the moment. It's a very dysfunctional country and a very odd country at times, but it's a very different healthcare leadership we're looking at. I wanted to talk just before I talked about the guidelines, because the guidelines are inextricably linked with a massive HIV testing campaign, probably the biggest ever initiated in the world, which is aiming to test 15 million South Africans. 5 million of them in Gauteng, I must tell you. The Gauteng Department of Health put up its hand and said, we'll be better than anyone else. I'm not sure how wise that was in retrospect, but they've done so. They've linked the testing. It's not simply getting an HIV test. They've fundamentally linked it to screening for other illnesses and for TB. At the time it was announced, I was a bit disparaging of it. I thought, why would you just go out and test everyone? But they've certainly linked the testing campaign. And the minister specifically is not interested in only getting an HIV test. He's interested in a whole lot of linked healthcare systems. He almost wants to test the healthcare system and to force the healthcare system to confront its inadequacies. He's very funny in meetings. He sits there and he says, yeah, you're just telling me excuses about why you can't do it. Get on with it. You've got all the resources, you've got all the money, you're not telling me why you can't get on with it. And it's a very interesting and different discussion from the one we had 10 years ago. The objectives of the program is to get people to know their status, to get them to improve their health-seeking behavior. They also want to stress the system around access to care, not just for HIV, but for illnesses. And they've instituted these nerve centers, both provincially and nationally, to try and pick up the information as to why the health system's not working. And finally, support people with key prevention messages. They also, I think there's a strong appreciation that we can't keep treating the epidemic. We have to start improving our prevention messaging. And that's another talk. And you can be a bit cynical. I'm always cynical about World AIDS Day themes, but they've chosen this I am responsible thing and about taking personal responsibility both for yourself and for your sex partners within your so-called sphere of influence, for us as doctors, obviously in the healthcare sector, and government is taking responsibility to ensure quality services. And certainly the minister is leading from the front. When the Tanzanian president launched their program a couple of years ago, he stood up and the press said, what's your status? He said, that's confidential, it's between me and my doctor, which was exactly the right message to send out, rather than, you must volunteer your status in public, which is a very personal choice. So this is going to, for the next year, is going to be ruling our lives, this campaign. There's been engagement with both the private sector in multiple forms, including with the pharmaceuticals, for the pharmacists, with many of the people who are promoting testing within the private sector as well, and with the GP networks. So as you all know, if you get onto antiretrovirals, you do very, very well. And 1 year and 2 year survival from developing world cohorts. If you get the tablets and you stay on the tablets, 90% of your patients should be alive at 1 year and 2 years. And in fact, the Botswana program, which has got data running out to 6 years now, shows that 90%, just under 90% of them are alive and well at 6 years, which is very similar to developed world data. There seems to be a slightly higher mortality rate here, which is probably driven by pneumococcus and TB. But if you can survive those first 6 months, your mortality rate returns to what you see in developed world cohorts. And in fact, after 5 or 6 years, probably returns to normal, almost for HIV uninfected people. And this is where there's a lot of data coming out. In fact, this was published last year in 2008 already. I must update my slides. But demonstrating that people are going to probably live into their 60s and maybe even to their 70s and 80s with the current drug regimens. These are all mathematical models. They're all things which obviously we haven't had the drugs for that long that we can model it with. But there is a suggestion that issues like HIV geriatrics and the issue of fertility, which you're all dealing with at the moment, are going to become huge things going into the future. The French study that I looked at, was that your life expectancy is normal if you can live through the first 6 years of antiretroviral therapy, and particularly through the first 6 months. American study suggested that in the current drugs that you lose in on average 12 years, which is probably less than what you lose with diabetes, which is an interesting observation. And the Danish study said that if a 25-year-old contracted HIV, they'd live in another 39 years. Oh, sorry, if a 25-year-old starts antiretrovirals, they'd live 39 more years. And there's a lot of confirmatory data coming out at the moment showing that people are going to live a very long time as long as they can take their tablets, as long as you can deal with the side effects. So what's changed in the guidelines? Well, the first big change is that the CD4 count is elevated to 350. It's a qualified elevation for adults. Okay, so this brings it into line largely with the private sector and with international thinking, which I'll come back to in a moment. Infants should be initiated immediately, and that's based on the SURE study, which came out of Soweto and out of Cape Town. Our own data that infants who are diagnosed by PCR should be started on antiretrovirals immediately, irrespective of their immune status. There's new maternal health and PMT-CT regimens, which are more effective and easier to take, actually just more effective. There are new first-line drugs for both adults and children. There's altered second line, which is probably as effective but less toxic. There's expedited referrals with timelines. This is one of the sections which I think is going to be the most difficult to initiate, but we'll get to. There's decreased blood monitoring, which is quite interesting, which came from the clinicians, not from government. And finally, there's a strong focus on nurse initiation. The feeling is there's not enough nurses, but there's certainly not enough doctors. And this stuff actually needs to be initiated. And there's ample evidence from the rest of Africa that nurses are both equipped and probably better than doctors to initiate antiretrovirals. So let's start with number 1. CD4 count of less than 350. Government, I'll come back to in the reasons why at the end of this particular section, but that said not for everyone. We said, listen, just give them for everyone. Make it 350, you come into line with WHO and other guidelines. They said only for pregnant women and for those with TB. For everyone else, less than 200 is going to hold. So what's happening at the moment, what's interesting is when I started out in HIV, CD4 count 500 was the aspirational thing in America. It swung all the way back to 200 in the early part of this decade. And then it appears to be swinging all the way back again. And the reasons for those who Dr. Rasmus and others were talking about earlier have to do largely with the long-term consequences of viremia, not the long-term side effects of the drugs. And we've talked about it in other meetings here, but particularly the consequence on cardiovascular disease, renal disease, and kidney disease, and liver disease suggests, in fact, that starting antiretrovirals earlier is probably a good idea. How early, we're not too sure, but I'll take you through the data in a moment. So you've got this train on the track model of a patient who's going down the track, whose CD4 count steadily drops over 8 to 10 years. There's lots of data on this now. And sometime they need antiretrovirals. Before that, we do a whole lot of stuff to them, which doesn't work really, but we do it anyway. And then we start the antiretrovirals. Where we start the antiretrovirals on this track seems to be steadily moving backwards, as we appreciate more and more how much harm the virus itself does. We know that less than 200 is much too low. And in fact, Steve Lawn from Cape Town has this amazing data, and he talks about the death zone. He says, if you wait till less than 200, you're waiting for the patient to enter the death zone. You should start the antiretrovirals before they enter the death zone. And there is ample evidence that we should be starting at least between 200 and 350. As I said, there's reason for why government is not doing that, but be under no illusions that once they go and they drop below 200, they are in high, high risk. And I think that probably is everybody's experience in this room. There are several studies that suggest actually that we may even need to go more than 350. And in fact, there's a study being initiated by the NIH called the START study. The preliminary results are going to be available to the DSMB in 2 weeks' time, but which is going to analyze starting above 350 versus delaying below 350. But there's several studies now which either indirectly or indirectly have suggested, in fact, that we probably should start antiretrovirals above 350. There's a big debate about this, and in fact, the benefit above 350 versus just below 350 is probably relatively small, but not insignificant. Below 200, it is chalk and cheese. And I think there's still a lot of debate about 350. And some of those ideas around it, that there seems to be increasing recognition of HIV-associated neurocognitive disorders, particularly in the last year and a half. For the last 3 or 4 years, increasing evidence that arterial stiffness, the lower your CD4 count goes, the stiffer your arteries and the greater your risk of stroke and heart attacks. And increasingly, this risk of fracture and peculiar effects on vitamin D metabolism, which we talked about also earlier this evening. There's also an increased risk of opportunistic infections. Now, that risk comes off a relatively low base, but it's not insignificant. And in a perfect world, I think if it was me, I certainly would want to be started above 350. The American guidelines now say, and it's really interesting to hear what's strongly and not so strongly recommended. There's no debate below 350. Between 350 and 500, this group of Americans, actually half of them strongly suggested that it should be started during that time. And in fact, almost half of them said that you should start above 500. So the pendulum is swinging that way. I would caution you, though, to say that the data to support this is highly controversial and probably relatively irrelevant, which I'll show you in a second. The kind of things that would favor starting earlier would be history of an AIDS-defying illness, which we would probably agree with immediately. So they've said certain acute opportunistic infections, particularly septicemias, pregnancy, HIV-associated nephropathy, and in fact the kidney is seen as one of the major areas where the HIV causes most of its damage now. Hepatitis B infection by itself, chronic infection, is seen as an indication for antiretrovirals irrespective of CD4 count, and high HIV RNA levels. So these kind of things would lend itself towards favoring this. These are the American guidelines, which probably, I think, are a little bit ahead of their time, but which probably indicate the most aggressive guidelines at the moment. The British guidelines are slightly more sober, but tend towards the same sort of evidence. I think the reason I say it's a bit of an academic debate, and many of you have seen this slide, is that in vast majority of the world, people initiate antiretrovirals below 100, including in most African clinics and certainly in most South African clinics. The only clinic I've seen above 100 is actually in Khayelitsha in Cape Town. And even in the private sector, the average CD4 count is about 130. But you can see here in South Africa in general, it's about 90. The country where it's the highest is actually Australia, where it's about 240. So even in America, most people are starting below 200. So you can make your CD4 count 800 or 1,000 if you want to. You know, when most people are presenting really, really late, that doesn't help very much. So some of this debate about when to start around the CD4 count is a bit academic. But certainly the state guidelines are now going to say, so any CD4 count for any WHO4, so any AIDS-defying illness, and for multi-drug resistant TB. Multi-drug resistant TB has got such a shocking prognosis in this country that you don't need HIV on board to make it worse. You treat them irrespective of their CD4 count. CD4 count of less than 200, or if they're less than 350 with TB or pregnancy. So those are the new guidelines. In children, all children less than 1 year of age, so all infants diagnosed through the PCR program, get antiretrovirals irrespective of their immune status. For those children who you miss and who get through the system, which is a huge number of them, and I'll come back to that in a second, between 1 and 5 with clinical stage 3 or 4, or where the percentage is less than 25%, or the absolute CD4 count is less than 750, they should be started. And for those more than 5 with clinical stage 3 or 4 or CD4 count of less than 350. So they actually been stuck in under the guise of adults for all kids below 350 would get it. I think there's more and more appreciation of the severe stunting that's happening in children with delayed antiretroviral therapy. And the pediatricians tell me all the time the horror shows of dealing with adolescents who look like 8-year-olds when they're actually 16 or 18 years old. So this is all very well and good. The problem with this programmatically is that we have to now expand PCR testing. As you realize, is that all these children are going to be positive if their parents are positive. You have to use PCR to screen them out. And we're going to have to roll that out across the country to all the antenatal sites and to the vaccine screening program. So this is massive. This what looks like a relatively small guideline, which is very, very important. It has massive programmatic implications for the country. The next thing is, why did they choose TB? Well, for those of you who understand, is that there's more and more evidence that TB is by itself a poor prognostic factor, both for morbidity and for mortality. We do ward rounds at my hospital every single Wednesday morning, and it's just patient after patient who's got fraught lungs. They've been cured of their TB, but their lungs are completely stuffed. Those patients who are admitted with active TB have this incredibly high mortality rate, who often have other comorbidities. We just know that patients with TB have a very poor prognosis, irrespective of their HIV status. And in fact, WHO's, as far as I understand, the new initiation guidelines are that patients with TB should get antiretrovirals irrespective of their CD4 count. And probably we will go that way in the future. It does mean a massive number of patients entering the system. But the study that was published from Durban, which demonstrated this very high mortality rate, is that we should be giving patients with TB antiretrovirals earlier and earlier, and certainly at probably before the 2-month period. As I said to you, if they have multi-drug resistant TB, get them onto antiretrovirals, irrespective of their CD4 count. The debate at the moment is, why not give it to everybody with TB? So you don't need a CD4 count. TB by itself is so severe and such a serious opportunistic infection, shouldn't we just give it to everyone? There is a debate about whether we should do that. We don't know how quickly to initiate antiretrovirals. I think most of us think as quickly as the patient will tolerate them. So often what will happen is we'll give them TB treatment. The second that the gastrointestinal side effects are settled, we'll initiate them on antiretroviral therapy. The thing about CD4 count of less than 350, though, has profound impact on pediatric HIV. And I think this is why I'm thrilled about the pregnant woman. And if I had one thing to say to the health minister, I have plenty of things to say to the health minister, but the one thing I would say is that treat the pregnant woman as your absolute priority. And the reason why is that this, from Louise Kuhn, who's I think landing in Joburg this evening, demonstrates in fact that in her study from Zambia, that 55% of all maternal deaths happen at a CD4 count of less than 200, and half of all postnatal infections. But she did one better. She looked at the 350 sphere, and she said if you treated all pregnant women, if you looked at all pregnant women, 85% of all maternal deaths happen at a CD4 count of less than 350. And you must remember, most of these are AIDS-linked. And over 80% of all postnatal infections. If we ran a perfect PMTCT program, we could almost remove 4/5 of all the pediatric HIV, and we could make a fundamental difference on maternal mortality, which I'll come back to in a moment. And for me, the CD4 count threshold being elevated to 350 was actually the PMTCT intervention. It's going to have very little impact on adult mortality, but it's going to have a fundamental impact on pediatrics. The final thing, I'm not going to talk too much about this because this is hugely controversial and obviously lots of fun, but there's evidence now that treating your patient is probably the most effective form of prevention. Now, you can't run out there and tell your patients this. And there's lots of data now to demonstrate that once your viral load is undetectable, you're pretty much uninfectable. And people hate this. The prevention people almost implode when you talk about it. But firstly, the prevention program results have been very disappointing, and we've got to keep working on them. But this idea that people are talking about now is if you reduce the viral load across the board in as many people as humanly possible, would you have a public health impact? And there's a whole lot of mathematical models, very controversial mathematical models, that demonstrate that perhaps we would have the most impact in prevention by simply treating the virus. This is a great convergence because we're saying treat people earlier and earlier. On the other hand, we're saying it's the best form of prevention. We might get the prevention and the treatment people to finally agree on something and actually deal with this. And the study that was presented at CROI, which is fascinating, it was a transmission study from one of the Central African cohorts, but showed that all the transmissions between discordant couples, 102 of the 103 cases of confirmed HIV transmission happened on those not on antiretroviral therapy. And in fact, the one transmission that did occur happened very early on in the initiation of antiretrovirals. I think it was about 2 or 3 weeks after initiation. So this is not, you can never do these kind of studies, it's very difficult to do these kind of studies in a randomized controlled way, but the evidence to suggest that making the viral load undetectable makes them almost undetectable, almost untransmissible, is very, very strong at the moment, much stronger than for most other prevention interventions. So the final word is from the Department of Health is they have said to us publicly at SANAC and every part, they actually want 350 for everyone. The problem at the moment was cost and burden on services, and that was the reason for the qualification. As I said, I don't think there was any reason to do that. I don't think the burden would have been much greater than what's going to happen at the moment. But the commitment is to move to 350 for all. And I think that you need to understand that. And remember, for those of you working in the state sector, that I generally think that if you don't have a long queue, and that patient has a CD4 count of 252, you should actually slap them on antiretrovirals. These are guidelines, they're not tablets of the law. You need to be a little bit responsible about that, because if you have a long queue of patients, maybe you should think about deferring it until the patient with a CD4 count of 3 gets it first. But where there aren't restrictions, I think you need to realize that the Department of Health will be going this way. Major change number 2, don't worry, that was the longest change in terms of explanation. It goes much faster after this. Why was tenofovir chosen for the adults and why was abacavir chosen for the kids? Okay, and this is a good question. And in fact, there was a very angry rural doctor who emailed me and wanted to know why this was done and was I in the pocket of the drug company. So I said, of course, and it's So the first-line therapy is that all new patients needing treatment, including pregnant women, will be given a combination of tenofovir and 3-TC or FTC. For those of you worried about the difference, FTC is similar to 3-TC. It's got a couple of differences which only the academics are interested in. But we will be retaining efavirenz as first line and nevirapine for pregnant women. I'm going to come to that at the moment. So in fact, this regimen of tenofovir, 3-TC or FTC and efavirenz, in theory, is actually the same as the most popular regimen prescribed in both Europe and America, which is a good news to us because it means that it's also easily the most popular prescribed regimen in private practice. For those who are not going to get tenofovir, the major contraindication is renal disease, and every single patient in the state sector should be getting a creatinine clearance going forward. And for those patients, they're going to get AZT with, instead of tenofovir. Now that is actually a pretty good regimen, and until about 5 years ago, this was the most commonly prescribed regimen in Europe and America. For those on existing D4T, we're going to leave them on, and many of you are going to be extremely unhappy about that, but there are over 1 million, they're probably in the realm of 800,000 people on D4T at the moment. If you shift them to tenofovir tomorrow, firstly, there's not the drug companies are not going to be able to manufacture that amount, but also you'll cripple the budget almost overnight. So what we're saying is that be vigilant and switch these patients who get toxicity across in a moment. And I'll come back to that also in a second. In fact, right now. So this is the old guidelines, D4T. The 3-TC and efavirenz, if they failed, they went across here. But I think we all know, and we didn't know this when we constructed the guidelines, in hindsight being 20/20 vision, I would have chosen AZT here in retrospect for our original guidelines. We realize how toxic this is, and I'm not going to tell this audience. I'm sure all of you have seen the toxicity. But the fact that we all blame the protease inhibitors for this, for the lipodystrophy and lipoatrophy that we see with D4T. But this was one of my favorites, mainly because this is a scan through an abdomen. Yeah, you can see a normal one with lots of gut gas and stuff in between. Can you see how the fat has packed in between the gut here in this patient that's visceral associated tissue? But you can see how much and this is an independent risk factor for cardiovascular disease, and is a direct consequence of D4T. And you've all seen these patients with their thin arms, the beer boop, and often the buffalo hump. And certainly this was on the front page of the Sowetan, and you can imagine, you can say, you can go on television as often as you like and tell them about ARVs. All you have to have is one severe form of gynecomastia, which again you've all seen, and it takes to pieces all the stuff about antiretrovirals being safe. And I think that getting rid of D4T for us is going to be hugely effective in terms of some of the PR problems we've faced with the program. How does it compare to the Americans? Well, the Americans like their protease inhibitors. But you can see here, they say that if you're going to choose an NNRTI, use that. And that's us. If you're going to use a boosted PI, they've gone with a boosted atazanavir or darunavir combination. It's interesting, they're not recommending Kaletra anymore, mainly because of the metabolic side effects. And they've now put in a first-line an integrase inhibitor in the form of raltegravir, which I'll come back to in a second. So we've got to ask ourselves, why aren't we using these? Well, I think from a South African experience, we think that protease inhibitors are relatively toxic. They're also very expensive. And we'd prefer, certainly if I was HIV positive, I'd much rather take efavirenz. And it's an excellent drug. I just love this title. What over 1 million years of patient experience has taught us. And I think that it's always important to look retrospectively at what these drugs are doing and how much experience there is. And there's a ton of experience with tenofovir. It's a very safe and very well-tolerated drug. So why didn't we use AZT? Well, I think it's a good question, but there is an element of lipoatrophy, much less than with D4T, but it's certainly there. Anemia, anything between 5 and 12% of patients will get significant anemia. And in fact, in Namibia, where they put AZT first line, they crippled their blood transfusion services almost immediately just through the requirements for transfusion. And I'm very pleased that we didn't use AZT, because I think we'd have to have a very strong training program and strong liaison with the blood transfusion services. Also, we're going to be using it in second line. So that's the reason why we're not using AZT. There would have been a cost benefit over tenofovir, but not a big one. Why not abacavir? Well, for kids, it's a fantastic choice, and there's actually a lot of data in kids, and that's why it's been chosen. In fact, this recent large study, ACTG 5202, was released 2 months ago at CROI, demonstrated, in fact, very little difference between abacavir versus tenofovir. And I think for most, why we shouldn't use abacavir, well, actually, it's largely cost. It still remains one of the most costly antiretrovirals, both internationally and locally, for reasons which are a little bit difficult to come by. There is no fixed combination yet available with, in the triple form. There's a very nice combination with 3TC in the form of Carvexa. There's issues around rash. A small number of patients do get rash. It's very rarely seen in black patients, but very rare when you're putting 1 million people on treatment, translates into a significant number of cases. There was some idea that it was less potent than other combinations, particularly compared to AZT, and I think most of us are relatively confident that it still works in most cases. So these are the reasons why we didn't choose abacavir, but it was largely cost, I think would be the primary reason. So why not tenofovir for children? There's a lot of concerns about tenofovir's long-term toxicity, both for the bone, for development, and for a range of other reasons. And that's why I think people steer towards abacavir. Why not raltegravir? And this is actually probably going to, within the next year, be the most prescribed regimen in developed countries. So combining tenofovir, 3TC, and then using raltegravir instead of efavirenz or a protease inhibitor. Well, there was, again, data, just to show you how incredibly current I am, from 2 months ago, demonstrating, in fact, head-to-head with efavirenz, they do exactly the same. And here you can see data running out to 192 weeks. 3/4 of the patients are actually viral load suppressed. Well, it's essentially cost. And that's unlikely to come down. It will come down, but it's a fairly dramatic increase in cost of efavirenz, which is less, is less than 100 Rand. The other thing is that they're going to go and test this on hundreds of thousands of Americans and neurotic Europeans before they bring it to Africa, which is always a very good thing, because they go and work out the side effects there before they send these drugs to us, which is. They took a while to get us triple therapy, but now that they've given it to us, I think the efavirenz is still a very, very, very good drug. And I'd rather maybe wait for the 1 million years of patients on raltegravir before I whacked anyone onto them willy-nilly and made the recommendation. So at the moment, it's going to be cost, but this drug is coming to our shores. It's an unbelievably effective drug with a very good side effect profile and very useful in second and third line patients, and possibly even in first line. I really think it's very exciting times we're living in terms of these new age drugs. First line for kids, well, abacavir is going to, and they under 3 years, mainly because there's very little data on efavirenz, they're going to be used Kaletra, boosted, and there's a lot of experience with Kaletra in this age group, and it works like a bomb. For children over 3 years, they're going to use abacavir with 3TC and efavirenz, and we haven't really discussed it yet, but I suspect they'll probably stay on that until they fail, which means that even if they live to 30, they'll probably remain on it. Abacavir in the long term appears to be a very safe drug in the absence of cardiovascular consequences. It's important to remember who's still taking D4T. In fact, the vast majority of people in the world are on D4T. And that's because most of them are living in Southern Africa, and it's a very, very cheap drug and very well tolerated for the first 6 months. But for those who are on D4T, both children and adults will remain on it as long as there are no side effects. None of us are particularly happy with that, but practically you can't transfer this number of patients into a tenofovir-based program. So just be vigilant, switch them at the slightest sign of toxicity, and hopefully eventually all our patients will be off D4T. So are there any problems with tenofovir? Well, supply, and I can tell you that that's already hit us. Across the country, there isn't enough supply. I was told yesterday by a very reliable source that from government that there's 40,000 months worth of therapy landing on our shores. The Americans are airlifting it into us, which will be available across the country as of today, I think, or tomorrow. And in fact, the drug companies are tooling up for it. The tender process hasn't been finished, which is, again, testament to the chaos within the Department of Health at times. But that is being addressed, and there is a commitment to supplying sufficient tenofovir across the country. Whether it actually gets there is a little bit less clear. Renal dysfunction is the major is the only real contraindication to tenofovir, but The creatinine clearance somewhat predicts. It's a bit like having an ALT when you have nevirapine. You can still develop renal dysfunction, and actually quite students I see in the audience, but has had experience with patients who've gone into acute renal failure with tenofovir. Creatinine clearance is going to be routinely measured on every single patient. We're not going to use Cockcroft formula. We're using the alternative one, which only uses gender and age. But they're going to calculate to create clearance, and if it's below 50, we're going to say, please don't use tenofovir. Use dose-altered AZT. How this is going to work, I don't know, and it certainly is not a public health approach, but I think it was a weighing public health and clinician worry about this. This is probably going to be something that goes forward. I must tell you that I was working out that even if only 0.1% of patients get acute renal failure, that it's going to be several hundred patients. If we moved every patient on D40 to tenofovir, we get 600 or 700 patients with acute renal failure almost immediately. So, and our dialysis services are extremely restricted. Major change number 3 is to second line. So second line adults is going to be if you're failing D40 or AZT, you will go on to tenofovir, 3-TC, FTC, and Kaletra or Eluvia. There's a lot of evidence that this is such a nuclear bomb of an antiretroviral. It doesn't actually matter what these two are, they'll work. But the general recommendation is that if you fail these two, you'll go to that. And if you fail tenofovir, you'll cycle through to AZT. The current recommendation is that the old guidelines said you'd go to AZT, DDI, and lopinavir. It's a bit of a nuclear bomb for the tummy, so it's very, very difficult to swallow those drugs. This is now, there's a lot of appreciation of the fact that if you recycle 3-TC, you triple the virus, and that resistance to AZT and thymidine analogs in general is very, very slow. If you go beyond second line, it's called refer. I have no idea where or how or anything, but it's like when they had all those terrible side effects with hormone replacement therapy, and they said, go discuss it with your doctor. It's like, what am I going to tell you? It's like, anyway. Second line for children is a similar thing, is that if you fail an efavirenz-based regimen, you'll go onto this, which is interestingly better tolerated in children than in adults, a Kaletra-boosted regimen with DDI and AZT, and that is really a nuclear bomb. I'm not aware of anyone ever failing that particular regimen. If they viral due to resistance, usually because they can't swallow the bloody tablets. If they failed on AZT and D4T, again, then they will cycle again to a protease-based regimen. If they fail that, you refer. And especially if they're less than 3, they'll be referred through to second line. And there's some provision to try and get third-line drugs like raltegravir to the tertiary sites. But I must be honest, I think in reality, if you're failing second-line therapy, there's lots of other things you need to do. And there's data here from Max Fox's group here from Johannesburg, which actually demonstrates very, very good results with these second-line therapies in South Africa, using the old AZT, DDI, Kaletra-based regimen. So I think that we've got a good drug in a protease inhibitor. It will work as long as the patient will swallow it. Monitoring, I'm going to get to that in details, but there's lipids at 3 months. If you lopinavir or ritonavir in adults, generally if the lipids are going to go up, they'll go up within 3 months, and then you need to treat it. In children, there's concern that we don't know what the long-term effects of that, and there it's going to be annual. Major change number 4 is getting people into treatment quickly. Now, this data again from Cape Town demonstrate a massive mortality. In fact, at 6 months, you can see here almost half the patients are dead if their CD4 counts are less than if their CD4 counts are low. And this, Paula Bratstein did this amazing simple little study where she just got the nurses to rush the therapy for the patients who had low CD4 counts, and she demonstrated a 60% decrease in mortality. So you can have all the funniest drugs and the most expensive lab tests. If you simply move them through the queue a little bit faster, you have an incredible impact on the healthcare system. So we have now come up with this as being, we want these patients to get treatment within 2 weeks of getting their CD4 count. Okay, and now I'll come back to the trick question here in a moment, but pregnant woman, okay, at Johannesburg Hospital for the first couple of months of our program, we had I think it was a 7-month waiting time from the pregnancy clinic to get to the antiretrovirals, which means baby was long done and dusted by the time they actually arrived at our clinic. Patients with very low CD4 counts, and we just thumb-sucked 100. Stage 4, so any patient who's very sick, or where the CD4 count was not yet available, or MDR, XDR, TB. All of these must be fast. Now, those astute ones amongst you will turn around and say, but if the average CD4 count is 87 when you start, doesn't that mean that the vast majority of your patients now should be getting treatment within 2 weeks? And the answer is yes. That's the reality. And I think that what we know is that we want pregnant women to get antiretrovirals very quickly for the baby's sake as well as for her sake, as I've shown you before. These patients have incredibly high rehospitalization rates, and faffing around with them puts a huge burden on clinics and on the hospital services. These patients are already fraught and they need treatment fast. And these patients need all the help they can get. And I think that once you pool this, it does mean that antiretrovirals in general should be regarded as a relatively urgent intervention. We're going to see whether this is possible. Children also get fast-tracked. Anybody with less than 1 year, in general, this seems to be happening in most of the sites. Again, if they're sick and their CD4 count's not yet available, and again in the case of TB. So very similar to adults. What about monitoring? Well, this is where I'm sure some of you are going to be very unhappy. Clinical stage is in the thick of it. CD4 count at 6 months and then every 12 months. This has been dropped from 6 monthly. Again, there were a lot of people who were saying, stop doing CD4 counts. Do it for staging and nothing else. And it's an interesting debate, is that what are you going to use the CD4 count for once they're on antiretrovirals? There's not a hangover lot that you use it for. There was a compromised position between the clinician's emotional state, we cry quite easily, and the public health people who were saying, duh, and this is how we came up with this compromised position, which means a lot less CD4 counts being done. The really hectic stuff, though, is the viral loads. We dropped the baseline viral load, which was very unpopular, particularly with the virologists, interestingly, from NHLS, and with good reason. But they're going to do it on month 6 and then every 12 months after that, which is, again, halving the amount of monitoring. Okay. No more liver functions in those patients you're putting on nevirapine. There's no data to suggest knowing the ALT does diddly squat. You need to wait till they go yellow and they start flapping, and then you need to look after them. And it's going to be really, really important, because I'm going to show you now the one thing the state has done, which I think is wrong, is all pregnant women are now going to get nevirapine. And that's, even if 1% of them get severe liver failure, that's a huge number of liver failures entering the system. And we're busy trying to work with government and with the MCC to try, and Viv Black in particular has done the most amazing fight, along with Ashraf and a whole lot of other people, to try and get that done. For those people who are going onto full blood counts, onto AZT, are going to get lots of full blood counts. And those who are going onto tenofovir will get lots of creatinine clearances, although it's not clear that either one of these two is going to stop the toxicity. As I said to you, those who get Kaletra, obviously the lipids are going to, and some of them is going to go up at month 3 for the adults and annually for the children, or for baseline. And by and large, the cholesterol tends to creep up at 3 months, and if it's going to creep up, and then we just have to treat it, or hopefully find an alternative drug. So why fewer viral loads? Well, the one thing, and there's data here from Johannesburg, from Wendy Stevens and our group, which shows that the development of resistance is actually very, very slow. And that's much slower, that you either get the resistance you're going to get to 3TC and the NNRTIs, you get almost within weeks or months, and it's a done deal. But the resistance to thymidine analogs accumulates extremely slowly, and particularly if you've got 3TC on board. And that, in fact, the protease inhibitors are a nuclear bomb, and in fact work even in the presence of severe resistance. The trick is to get your patients to swallow them. And if you get them to swallow them, they almost always will suppress to 0. So the feeling is that the viral loads are not doing a hell of a lot to guide your care. There are a lot of debates about this, including saying that it's one of the few markers of excellence of a program is the viral load. And as you go into primary care and as you expand this program, maybe we need more viral loads rather than less. And I think that is a legitimate question, a legitimate comment. What about mother-to-child transmission? Well, I just want to show you this, our MDGs. I love this graph, because it shows that the Millennium Development Goals are this big political thing that we're supposed to be aspiring to as a country, as part of one with the rest of the world. The problem is that South Africa's maternal mortality has actually gone up as opposed to down. And in fact, if you look at our maternal mortality here, and you compare it to our country cousins on the border across the road, you can see that we do really, really badly. It's really worrying when your maternal mortality is higher than the woman in Iraq. And it really is testament to the fact of a fractured healthcare system thanks to Mantu, but also the fact that HIV is taking a terrible, terrible toll on mothers. And you could say, oh yeah, but we're a middle-income country or lower-income country. But if you look here and you look at the Millennium Development Goals, you can see here that countries like Chile and Brazil are well on their way. In the case of Chile, they're already there to getting the Millennium Development Goals. And you can say, look at our country cousins next door. In Namibia, they're on their way, and they'll probably get there by 2015. South Africa, that's the number. There's no way, even if we turn the whole thing around and we do that, we're never going to get those goals. And as I said, it's easy to throw up your hands and say, we're not Brazil, we're not Namibia, we're not Chile. But Namibia's spending on healthcare systems a hell of a lot less than ours is. So this has become a huge issue. Treat mom, baby will be treated properly. And in fact, as I said to you, any mother with a C4 count of less than 350 is going to be put on tenofovir 3C and nevirapine, and as quickly as possible, theoretically within 2 weeks. And this will have a massive impact on pediatrics and on maternal health if it's done correctly. I'm very worried about nevirapine, as many of you who've used nevirapine know, but there's this big thing about the package insert and all the rest. If you're a doctor, you are allowed to use efavirenz during pregnancy because you can prescribe off because they're guidelines. If you're a nurse, though, we need actual official pronouncement on the issue of prescribing efavirenz. So those of you who are involved with pregnancy, please use efavirenz. Most of us think that the issues around teratogenicity are absolute nonsense, or that there's no more or less data than nevirapine. But this is going to be a real problem for nurse-initiated therapy. If they're not eligible for ARVs, if their C4 count's more than 350, we give them AZT from almost the second they walk through the door. Single dose nevirapine at delivery, and then Truvada after delivery. Although we haven't got Truvada just yet, we might have to use some tenofovir. But the importance of this is that, but if you do that right, this we will take care of the vast majority of the transmissions. Most of us say, well, why don't you just treat all pregnant women, just give them antiretroviral stoma? But this is the alternative antiretroviral regimen that's going to be done. If you did both these right, you'd probably cut transmissions down to less than 5%. If they're unbooked and they present in labor, you give them single dose nevirapine, and then you give them Truvada for 1 week after that, which is supposed to protect the tail from, and there is some data to suggest, from Africa to suggest that that's effective. The important thing here is we've encouraged repeat HIV testing during the pregnancy. There's a huge number of women who seem to fall HIV positive during pregnancy, which suggests they're having unsafe sex during pregnancy. And in fact, in Botswana, which is a very big, very, very good PMTCT program, almost half the transmissions now are ascribed to acute seroconversion during pregnancy, which is quite something. Those of you who find this a little bit difficult to follow, I save it on my cell phone because I can never remember it. And it is one of the most complex interventions known to medical kind. But just when you thought it was easy, then the infant regimens came along. If the mother went on to lifelong antiretrovirals, you put them on nevirapine at birth and then daily for 6 weeks, irrespective of infant feeding choices. So whether they choose to breastfeed or to formula feed, you give them the nevirapine as post-exposure prophylaxis. The thinking is here, and there's lots of data to support it, is that if the mother's on successful ARVs, the transmission through breast milk is very, very low. And that in fact, there's a lot of data to suggest that breastfeeding is actually very, very important. It carries a cost in terms of transmission, but the mortality risk in terms of diarrhea is high. If the mother's on AZT, you give them nevirapine at birth and then daily for 6 weeks for afterwards. Continuous you give the baby nevirapine at birth and then daily for 6 weeks, as long as there's any breastfeeding. Some of these recommendations might strike you as a bit odd. Some of them are not evidence-based. Most of them fit within the WHO framework. If the mother did not get any ARVs before or during delivery, you give nevirapine as soon as possible to the baby and daily for at least 6 weeks, continued for as long as any breastfeeding. Obviously, this child, if they do contract HIV, is going to have NRT resistance up the wazoo. Next issue is nurse initiation of therapy. Now, this has been done across Africa. In fact, it's been done in developed countries, and in our country has become a source of much debate for reasons which I cannot quite understand. I do, however, think, and this still remains one of my favorite cartoons of all time, because this happened, especially since I work in Hillbrow, and this actually, we thought he might be dead, then he realized where we were taking him, and the patient's running away. I must be honest, I do think that things have improved a little bit in the last little while, but within the state sector, we are dealing with a huge perception of poor service. The funny thing is that within the state sector, for the STDs, TB, and for antiretrovirals, the outcomes are actually better in the state service because people follow algorithms, while in private people do follow their own intuition, which is often wrong. Having said that, people don't really care if you follow the algorithms if you're really rude to them at the door. And in fact, I just want to put up here some of the things around cross-country comparison of physicians. People keep telling me we can't do this, we can't do this. Well, if you look at the number of nurses per 100,000, our nurse density compared to Botswana, it's almost half of that. As I said to you, 2/3 of what, 3/4 of what Namibia enjoys. So when we start crowing about how we can't do this, we can't do this, other countries with far fewer resources have actually managed to get nurse-initiated therapy going. So I have very little patience for the idea. Having said that, you can see that we do have a lack of nurses in our country compared to other rich countries such as the United Kingdom and the United States. What's interesting here is the percentage of vacant posts in the public health sector for health professionals, and this is something we have to deal with, is the fact you can see that in some of these provinces, up to 60% of the posts are vacant. And again, this talks to the weakness of the healthcare system and the HR systems. Often the money and the budgets are there, but they just haven't advertised the post. I can bore you more with this. I thought it'd be interesting, though, to show you the disparity in 2004 between the different provinces. And you can look here that in Gauteng, we've got 126 medical practitioners per 100,000, while in Limpopo, they've got 18. So there might have to be a different way of doing things in the rural areas and the less resource provinces compared to our own. And some of this pressure for NHI has come, thanks to my boss for these slides, but you can see that this dramatic, the difference between public sector employment and the registration of the professional bodies overall is that less than half of all these people are actually working in the public sector. And particularly in the case of pharmacists, a tiny percentage of them were working there. And this is, I don't know what your opinions are on NHI, and I'm sure every single person in the room has one. But this is creating a lot of political pressure on people to try and bring some of the resources in the private sector across to the public sector. And whether that's good or bad, I don't know, but we'll see. The targets for this, well, we're supposed to have started earlier this month, and by next year they want to attain 80% of need. They want to put 420,000 people on antiretrovirals, of whom about 10% should be children, per year. To give you an idea, they're putting on about 250,000 at the moment per year, and that's about after 6 or 7 years of the antiretroviral program. This is going to be a significant increase on previously. And the only way you're going to do that is by expanding to more sites and getting nurses to do the treatment. So what can stop us? Well, human resources. I've talked to you about budget and treasury. I'll talk again about, for me, the bureaucracy and legislation. It's amazing South Africans' excuses. Every time I say, can nurses give antiretrovirals? No, it's illegal. Can counsellors prick blood? No, it's illegal. And they're not allowed to in terms of the Nursing Act. I'm like, why would the Nursing Act talk about counsellors? There's a lot of creative legislation that comes on. And in fact, unpacking that has been very difficult. And I think we've got far more idea of what nurses can and can't do and what counsellors can and can't do. Obviously, doctors can do anything. And recognizing that the context of care, this is a photograph taken in the brothels in Hillbrow versus a shack in a squatter camp versus these incredibly rural areas that we've. So there is going to have to be some nuancing of the program according to where you work. And I think that what's interesting to me politically is that at the moment, our primary healthcare center is predominantly nurse-driven. One of the things that shocked me was a study done which showed that in a country where the government has supposedly, Mantu and Zuma, her predecessor, were both trained in primary healthcare. They put tons of resources. They displaced away from the tertiary hospitals, and I think many of us would agree with that, is moving things to primary healthcare. The absolute number of people who attended primary healthcare sites in the last 10 years has actually dropped. And I think that suggests that people do not have confidence in our primary healthcare clinics. And it's a real indictment on the previous administration that suppose all the rhetoric that they haven't actually been able to improve primary healthcare. And that this intervention around antiretrovirals will be made or broken at the sites of the primary healthcare sites. And this is why we constantly deal with this tension, is that it's sometimes easier just to put a vertical program in. Go and try and repair the healthcare system. Honestly, you really have got no chance. Why don't you rather just go and do this? And that's creating a lot of tension because you can do this. You can have antiretrovirals, PMTCT, TB. You can have all these easily verticalized programs which work independently of the programs which the government has going. And there's a big debate as to how we're going to actually develop more integrated programs, or do we just do each thing in its own silo? The other thing is prevention, and that again, there are between 2 and 3 new people infected for everyone who commences therapy. So everyone you started today, 2 or 3 people got infected tonight. And we can't continue this. And the minister is quite clear about this. We have to fix prevention. We cannot keep doing this. We cannot be putting 420,000 people on antiretrovirals for the rest of their lives ad nauseum. There are legal issues around nurses dispensing, which are being addressed, and we actually have broken through that, and they've got clear information in SAC that there's a clear recommendation, there's a form you fill in, and you can get nurses to prescribe, as long as they've got the proper training. There's a whole issue around pharmacy dispensing. For instance, I was told it's illegal to give antiretrovirals for more than 1 month. It was very easy to ask the legal experts yesterday at SANAC, and they said that's absolute rubbish. Again, it's creative legal thinking, and in fact, you can dispense for as long as you need to. I think it's up to 6 months, in fact, the pharmacy can dispense. But these things, clarifying them becomes, people just throw them as impediments to expansion of the program. The only part of the budget that was pretty much increased across the board was the antiretroviral program. It received a 33% increase in injection in cash, which is massive. And this is including job creation, housing, all of those things which we know and love. Everybody else was flatlined over the last little while. And with inflation, that means decreased expenditure. So in a recession, the antiretroviral program got a massive increase in resources, which I think recognizes the fact that we can measure our stuff and Treasury trusts us to do a good job. Having said that, that's not going to carry on forever. So here we have our community care center. I just want to show you very quickly that you might be saying, oh my God, I can't do this, but it can be done. And we've got a very good illustration in Central Hillbrow. So we've got Johannesburg Hospital and Selby Hospital next to each other as tertiary centers. We've got the Hillbrow CHC and South Rand Hospital and a whole range of 14 clinics around them. So we have this, again, thanks to Regina who put these slides together. I would never be able to do anything this sexy. But you can see this idea of a tertiary center supported by secondary centers, supported by primary health. This is all the rhetoric government has come up with. And in fact, if you look here, we've started, I just want to show you the indication of how many patients we started. And I just have to explain this graph. It's quite difficult. Is when we started in April 2004 with the rollout, we were putting on between 80 and 100 patients at Johannesburg Hospital on treatment. And we did a calculation. We worked out that about 500 people were dying every single year in Hillbrow from AIDS. So we were treating about 20% of the people who were actually dying. Government subsequently came up and said, you must treat 80%. So that makes 400. It's very nice having these round numbers, as you can imagine. What happened though is then we had this, and you might say, and you can see here, we went up and up and up. We came close to this 400. We came close to the 400. And suddenly here, just in middle 2008, we actually got there. That big dip, by the way, was the national strike. So we actually got there. Then, thanks to the huge implosion and the xenophobic violence, there was this huge influx of Zimbabweans into the area. So we had to re-look at all our numbers and look at the census figures. In fact, we worked out, in fact, it's close to 780 people are dying every single month in Hillbrow, which means that 80% of that is about 620. And you can see here, by just working with the primary healthcare sites, working with Hillbrow, working with the hospitals, you can slowly crank it up. And in fact, you can see here that in January, February, we actually well outstrip the 80%. You might just say that that just indicates far more Zimbabweans have come to Hillbrow, but it's certainly possible. But you can actually, working very intensively with the TB clinic, the mother-to-child program, improving HIV testing, you can get to that magical 80% number. And in fact, the Hillbrow site is initiating almost 5% of the entire country's antiretrovirals within one little sub-district. So just to finish off, it was a very strange consultation project process, and I think that hopefully it'll be a little bit more coherent next time. I'm very sad that we didn't get hepatitis B screening at the start of it because hepatitis B is common and it's a reality. There is very firm indications for when you're switching from tenofovir that you should be checking hepatitis B status. And those patients with chronic hep B must be left on tenofovir. Otherwise, they run the risk of fatal hepatic flare. The issue of nurses needed to be clarified, and that is slowly being clarified, but it would have been good to have it done by the 1st of April. The mother-to-child issue, and particularly around nevirapine, is still a big tension point, and is going to, I suspect a lot of women are going to die during pregnancy because of nevirapine-associated toxicity when they didn't need to. And it's because of a stupid regulatory hurdle that unfortunately could have been tackled months ago. Fixed dose combinations is still an issue, and we're very strongly advocating that a triplo or whatever its generic equivalent comes through, because over 90% of the patients are going to be on tenofovir, 3-TC, and efavirenz. So I think, all in all, it was, as I said, I think they're solid guidelines. I think I've highlighted the ones I think which are problematic, and I'm sure many of you will tell me other things they found that are problem. There are a whole lot of inconsistencies which happened during the editing process, but I think the next round of them will probably happen within the year, and we'll hopefully clear up most of those. So yeah, I guess for all of us, it is hello the future. Now that I'm almost scared to put this up because of the FIFA worry and MTN being their official sponsor. But I think that we have taken quite a firm step into the future. There were a couple of us when they put AZT forward as first line, we were saying, we're actually going to, as the clinician society, we're going to leave this process because it's wrong. But I think that I'm glad we stayed the course because we managed to get back to tenofovir for adults. There were some real problems as well with the pediatric guidelines which were fixed. But I think that we have taken a fairly bold new step into the future. There's lots of stuff that needs to happen. I don't know what tenofovir is going to do to our dialysis program. I don't know what the side effects of abacavir are going to be in children. I heard of the first abacavir hypersensitivity in a black child. You know, all those things I think are things we're going to have to grapple with huge numbers of people going on to antiretrovirals. But I think it's a good move.